Hi everybody, I'm Stefano. How are you? You can write some message in the box below. If you want to start the conversation, please let me know if you are listening to me or there are some problems with connection. So I will understand if we are able to start or not this webinar. Alexander, hi. Hi Alexander. Yelena, hello. Forgive me for my pronunciation is not so good. Yeah, I'm an Italian guy, and so I'm not so able to speak in your language. In Serbian. David, Miroslav, Dorde, who is typing? Ivan, hello, Ivan. Okay. How many people attended? Okay, 25. Great. Danilo, are you here? Look, okay. Zdenka. Hello, Zdenka. Olivera. Milan, great. Great. So I think that we can wait just a few minutes till 35 and then I can start the webinar. Just to introduce you, I start the webinar and talking about the role of the fascia and just to introduce you the method. I'm Milos. And if you wanna ask me some questions, please write down the message below on your right. And at the end of the webinar, of the lecture, I will try to answer you, because during the presentation, during the lecture, I'm not able to read the messages, and so write down, and at the end, I try to answer to you. Hi, Danilo. Danilo, at the end of the lecture, you can habilitate the microphone. If you can also do now if you want. You can just you can, if you want to say something at the end or give us some information. So you are a presenter too, like me, and so you are able to change your situation, your yes. Also the webcam you can activate. Okay. Oh, this name is too difficult to pronounce. Hello, good morning. Yes, but I'm not able to read this kind of alphabet. It's too difficult. Milana Simic. Yes, hello. How can I say this name? It's too difficult to. I don't know. It's very okay. Georgie. Oh, okay, great. Georgie. Okay, it's good, Georgie. Okay, perfect. So, okay, guys, I think it's time to start. I try now to share my screen saver so we can start the presentation. Please, if there are some problems, write me something. If the connection is not so good, if you lose some words or it's not so easy to listen to me, write me down and I will check if I can resolve the problem. So presentation, let's try to share my screen. Okay, great. I can do this. And this one. Okay. Great. Are you watching this the lecture? Okay, if you do this, let me know. Okay, this is the presentation, the lecture. Are you able to see it or not? Give me a confirmation so we can start. Just a yes. Perfect. Thank you so much, Elena. Thank you. Great. Let's start. So, perfect. Today we'll talk about okay, the fascial manipulation method, of course. This is just a webinar to introduce you the method and try to explain you how the fascial manipulation works and why it's so effective for the treatment of the musculoskeletal pain or dysfunction. So today I will introduce you something about the theory of the fascial manipulation. We will talk about especially of the anatomy of the fascia, and then I will share with you some concept about the practice of this method. Just a few things to better understand how the fascial manipulation work and why it's so important for me that I am I'm a physiotherapist, and so I am also a fascial manipulation teacher. I live in Padua, near Venice. I'm 37 years old, and I'm so happy to be here with you today. And thank you so much, Danilo, to permit me to share this information with all of you guys. And so let's start. I would like to start this webinar talking about the main actors of this method, that are Luigi Stecco, Carla Stecco, and Antonio Stecco. Luigi Stecco is the creator of this method. He is a physiotherapist too. Now he's 71 years old. And he invented this method something like 30 years ago. And now Carla and Antonio Stecco are developing this method a lot, especially in the last 10 years. They are doing a lot of researches, many researches, and you can find them, for example, a lot of papers, scientific papers, for example, on PubMed. And later I will discuss about this. Carla Stecco and Antonio Stecco are both medical doctors. And the first one, Carla, is a professor at the University of Padova. Antonio Stecco is a professor too, and he collaborates with the University of New York. That's it. So let's talk about the method. Excuse me, guys. I will just to be sure that everything is going okay. Nobody write me that you're not listening. Okay, great. The method is very easy to understand because we would like just to maintain our body segments in balance one with each other. That's it. And we think that the myofascial structures, especially the fascia, this great, very important connective tissue, we think that it could be strongly related with the pain, but also with the musculoskeletal dysfunction. So we would like to restore the balance of the body, treating the fascia. Because as we know, especially in the last years, we know that the pain is not related only to the central nervous system, but probably it has specific relations with the peripheric structures, especially with the fascia. And today I would like to underline the role of the fascia because we think it's very important, and we have to know its features because for our clinical practice is very important to better understand the pain of the patient. So let's talk about the strong points of the fascial manipulation method. The first one is that every single patient is different from each other. So we don't use absolutely fixed protocols. If we have to treat, for example, 10 patients with the same pain, for example, on anterior part of the shoulder, we will treat them in a differently. Each patient we will treat in a different with different treatment. We will treat different segments. We will treat a different point because each patient has a different story. So I would like to underline this aspect. We don't use fixed protocol. Each patient has his own story, and so each patient has developed different compensations. The pain on the shoulder is just the last ring of a chain. It is just a tip of an iceberg. We would like to find, okay, the origin of the problem and treat the segments that we think are related to the present pain of the patient. But surely, frequently, each patient has a different story, so each patient has to be treated in a different way. Of course, because the connection of, thanks to the connection of the fascia is create a continuity in all of the body, and later we will understand how. Our method has a global approach, and to better understand how to treat the patient, which segments to treat, which points to treat, we use a tool that for us is very, very important, that is the assessment chart. Then I will tell you how, why it's so important and how we use it. The treatment is performed distant from the site of the pain because of the continuity of the fascia, and later you will understand better why we treat the patient distant, away from the site of the pain. The treatment consists, we find some specific points and we treat them, just generating a friction on these specific points that we call CC, center of coordination, using just the hands or the elbow. When I talk about the hands, I talk about the knuckles, the elbow, and also the fingertips. Okay, these are our tools to create this friction and release the tension on this specific point. The great thing is that the results are observable immediately by the patient, of course, but also by the therapist, just at the end of the treatment or after 2 or 3 points treatment. You can observe the result immediately, and this is good because we already understand if our hypothesis is good, if the segments or the points that we have chosen are the best one or not. Because the patient, if we treat the good points, if we treat the best points, the patient improve his pain immediately. If we have not chosen the best point of, or our hypothesis is not the best one, the patient doesn't change his situation. And so we are able to understand it and change our hypothesis or change our points already during the same treatment. Like I already told you before, in the last 10 years, we created a lot of scientific contributions. On PubMed, you can find more than 100 papers. Luigi, and especially Luigi, has written a lot of books, more than 10. And 5 years ago, Carl Stecco has written the first atlas of human fascial system, that is this book. This is very, very interesting. I like it so much because it describes in a very, very well the continuity of the fascia and the interaction of this connective tissue with all the elements of the body. Because, you know, during the university, I'm talking about, for example, the Italian university, we have studied only the muscles, the nerves, the bones, the brain, but nobody has told us about the fascia and why this connective tissue is so important. Now with this atlas, you can understand many things, and it's not this book is not important only for the fascial therapist, but it's very important also for the manual therapist in general, osteopaths, chiropractors. Is very, very good, and think that you can learn a lot also for your specific clinical practice. So I suggest you this book is very, very good. About the courses, we started each year, of course, before the COVID situation, more than 100 international courses. And in Italy, we have 30 courses per year, and so more than 1,000 participants per year. And we are so proud talking about these numbers. We think that we are doing a good job. So we are planning courses in all over the world, 60 countries in all over the world, and this is so good, and we are so happy about these results. And I hope to come also in your country, in Serbia, to introduce you this method. I think that it will improve your clinical practice. So let's start talking about the theory of this method. I would like to check if everything is going well. There are some questions. Okay. Are you sleeping or are you still with me, guys? Okay, let's go. If there are some problems, everything is fine. Great, let's go. So let's talk about the theory. So what is the fascia? Okay, I would like just to introduce you that the fascia is a connective tissue. You have to imagine it like a suite. Do you know Spider-Man, for example? You have to imagine the fascia like the Spider-Man suite. So a three-dimensional web of tissue that covers all the body, from the head to the toe, on the back, in the anterior part of the body. So the fascia is present everywhere. And of course, it has a lot of connection with a lot of elements in the body. So with the skin, with the muscles, with the nerves, with the bones, capsules, visceral organs, and so on. So we have to remember that the fascia is just a suite that covers everything, okay? I would like just to underline this aspect that the fascia is not, okay, the connective tissue, okay, but it's just a subclass of the connective tissue, because the connective tissue is represented by a lot of elements: meninges, perinerve, tendons, periosteum, aponeurosis, capsule, and so on. There is also the fascia, that is just a subclass of the connective tissue with specific histological features and linkage that we have absolutely to know, because our treatment belongs to this aspect. That's why for me it's very, very important the anatomy of the fascia. Because if we understand the anatomy of the fascia, we will understand how to treat the patient. So today I will underline these aspects because, in my opinion, are very important. If we know where we are, what we are treating, our treatment will be much more effective. Okay, we will improve the situation of the patient. If we don't know the anatomy, in my opinion, the treatment will be not so good. Okay. So remember, fascia, Spider-Man suites that cover all the body, and has a specific connection with a lot of elements in the body. And now we will understand why and how. Please study very well this picture. This is very, very important, okay? These are the fascial planes and are very, very important for us. Let's start to check them. So, this is the epidermis, okay? This is the derma. The first thing that I would like to share with you is this. There is not only one fascia, but we have two different kind of fascia. The superficial fascia, that is this layer, and the deep fascia, this second layer. The deep fascia cover the muscle. In the first and second level, okay, the course that we will plan next summer, we will talk about the deep fascia, and I will teach you how to treat this kind of fascia, because this kind of fascia is strongly related with the pain of the patient, with the musculoskeletal dysfunction, so coordination, proprioception, nociception, and so on. Okay? But it's very important also to understand the role of the superficial fascia. Look, the superficial fascia is this thin lamina that organize all the subcutaneous tissue. The superficial fascia is very thin. From this tissue born a lot of links, chains that we call retinacula cutis superficialis, that have this linkage have a vertical direction. These retinacula cutis superficialis are present also in these deep structures. These are this linkage, these chains that connect the superficial fascia with the derma, okay, above, and the superficial fascia with the deep fascia. So these retinacula cutis, these are oblique, these are verticals, connect all of this structure together and organize all the structure. They are very important because they organize the fat lobulus that are present there and there. But yes?
We cannot see presentation right now. Just turn it on one more time.
Okay, it disappeared.
Yep.
Let's try. Oh, why?
I don't know.
Because there is. Let's try another time. Okay. The last 5 seconds, Danilo. I repeated the superficial fascia. Do you see another time now?
Yeah.
Do you see it now?
Yes, yes, yes.
Okay. Let me know if there are some problems. Okay, Danilo?
Yes.
I repeat, so this is the superficial fascia, okay, that organize the subcutaneous tissue. From the superficial fascia comes out this linkage, this chain that are the retinacula cutis superficialis that have this vertical direction, and the retinacula cutis profundis that have this oblique direction. These lines, these links, connect the superficial fascia with the deep fascia and with the epidermis. These links, these chains are very, very important because they organize the space of the fat lobulus, but also protect, okay, the blood vessels that are inside of these tissues, the lymph vessels, and also the nerves. So the superficial fascia is very important for a lot of things, and later we will understand how. So remember this picture is very, very important. Remember that our target is not the derma, is not the superficial fascia. Our target, our friction, our points, we will find them on the deep fascia. So we have to understand that we have, with our fingertips, knuckles, or elbow, we have to bypass all of these tissues and go ahead to the deep fascia. That's it. If you treat the points here, or for example here, you are not able to be effective. You are not able to reach deep fascia. So the patient doesn't improve his pain. You have to bypass all of these structures and reach the deep fascia. Not the muscle, but the deep fascia. And then we will understand how. So remember this image, and I would like just to share also this image with you, these pictures. This is the fascial planes, like I already told you. This is a cadaver dissection. This is the skin. This is the superficial fascia, this thin layer that divides the skin from the deep fascia that covers the muscle. That's it. This is another picture. This is an echography, okay? This is the skin, okay, an ultrasound image. This is the skin. This is the superficial fascia. Look, this is a thin layer. These are the retinacula cutis superficialis and retinacula cutis profundis. And this is the deep fascia that cover the muscle. The last thing, this is an histological, okay, picture, skin, retinacula cutis, okay, that have a vertical direction, superficial fascia, these are the fat lobulus, and below we find the retinacula cutis profundis that connect the superficial fascia with the deep fascia that covers the muscles. Okay, remember, we have to reach the deep fascia for the treatment of the points. Let's see some other pictures about cadaveric dissection. This is, for example, the superficial fascia of the neck and the thorax. Look, this is the superficial fascia that covers, okay, the thorax and the neck. Look, these are the fat lobulus. Carla lift the superficial fascia and permit to show you the deep fascia that cover the pec, the muscles of the thorax. In this case, this is the great pectoralis muscle. This is the superficial fascia with the fat lobules that are present below and above this tissue. Okay? Another images. Look, this is the superficial fascia in the limbs. Look, this is the leg. This is the ankle. Look, this is the superficial fascia lifted. Carla has removed the fat lobulus from the superficial fascia. Below, we can discover the deep fascia that cover the muscle. Another image, skin, superficial fascia, deep fascia that cover the muscle. The last picture, the third one on our left, the right, this is the superficial fascia that cover all the legs. You can see the blood vessels, you can see the lymph vessels that are present inside of the fascia. And the superficial fascia is very important because it permits to protect them. And without superficial fascia, we can have a lot of problems. And now we will understand why. Because look, this is another image of the leg. This is the saphina venus. This is the ankle. Look, this superficial fascia is strongly connected with the adventitia of the saphina. It's very, very important because protect these vessels and permit to the vessels to be maintained open. Look, you can find also a lot of lymph vessels inside the superficial fascia, but only not only lymph vessels, but only superficial lymph glands. This is another image that represent the lymph vessel inside of the superficial fascia. In the superficial fascia, we find also a lot of elements about, for example, and we are talking about Pacini and Ruffini corpuscles. but also a lot of free nerve endings. So if we talk about the superficial fascia, we talk about a structure that have a lot of blood vessels, a lot of lymph vessels, superficial of course, but a lot of free nerve endings. So the superficial fascia is strongly related with the esteroceptions, okay, with the sensation of esteroception. But this is not our target, especially for the first and second level course. Our target is the fascia that is deeper than this, that is the deep fascia. And the deep fascia is organized in this manner. So remember this picture, okay? Now we already talked about all of this subcutaneous tissue. We have understood how it is organized. Now we'll talk about this tissue that cover the muscle. The deep fascia, we have two different types of deep fascia. We have the aponeurotic fascia and we have the epimysial fascia. They are just two subclasses of the deep fascia, and they have two different skills. The aponeurotic fascia, it's present just, remember, it's present just on the limbs, in the inferior limbs and on the upper limb. And it is present on the trunk, but just over the abdomen, forming the rectus sheath, and in the back, forming the thoracolumbar fascia. So remember this, the aponeurotic fascia is present only in the limbs and in the trunk, but in the trunk only represented by the thoracolumbar fascia and the rectus sheath. You have to imagine this kind of fascia. For example, if you talk about the inferior limbs, you can imagine the aponeurotic fascia like a silver stalk, okay? So a structure that cover the limbs from the toe to the hip. If we talk about the upper limb, we can think about the aponeurotic fascia like an evening gloves. So a structure that cover all the arm from the fingers to the shoulder. That's it. If you think about this kind of fascia, if you think about an evening gloves, if you think about a silver stock, they are structures that you can easily remove from the structures that are below. So remember that the deep fascia, you can remove it from the muscle that stay below in an easy way. The epimysial fascia, it's another subclass of the deep fascia, and this fascia is present everywhere in the body, everywhere, because the epimysial fascia covers very strongly, is strongly connected with the muscles. So it is present everywhere. And so it is present below of the aponeurotic fascia. The epimysial fascia is very thin and is much more elastic than the aponeurotic fascia. The epimysial fascia has something like 50% of elastic fiber because he has to adapt his structure to the contraction of the muscles. The aponeurotic fascia has just 1% of elastic fiber because he has just to transmit the forces between from one segment to another one. Because if you imagine this aponeurotic fascia like an element that connect more than one segment together, he has to connect them and transmit the forces. So the elastic fibers are very poor, just 1%. So this is the aponeurotic fascia is thicker than the epimysial one. The epimysial one is very thin. The aponeurotic fascia is much more strong because he have to connect and he has to transmit the forces. So this is what I'm talking about. This is the skin lifted, and if we lift the skin, you can find the fat lobulus. Inside you can find a lot of blood vessels. This is the region of the thigh, okay? So it's the inferior limbs. If we remove of the fat lobulus, we can find, look, the superficial fascia. Then we are in the limbs. So below the superficial fascia, we can find the aponeurotic fascia, okay? So this is, for example, the silver stalk of the inferior limb. Like I told you, the aponeurotic fascia, you can lift in an easy way, okay? You can detach it in an easy way. So Carla detached it. This is the aponeurotic fascia lifted. And below we can find the epimysial fascia. Look, this is the epimysial fascia that cover the muscle. So, superficial fascia, aponeurotic fascia, epimysial fascia. And this is what we can find in the limbs, in the inferior limbs and the upper limb. Okay? Are you with me, guys? I know it's not so easy, but if you have some question at the end, please write down, and later I will answer to you. So now let's talk about the aponeurotic fascia. Okay, so let's talk about the silver stalk and the evening glows of the body. The aponeurotic fascia, okay, is able, like I told you, to transmit the muscle forces over a distance. It consists in 2 or 3 parallel collagen fiber bundles. So it consists in 2 or 3 layers that are composed of collagen fiber bundles. These layers are able to transmit the force in three-dimensional direction. So one layer transmit the forces, for example, in this direction. This is the yellow one. Another layer transmit the forces in another direction. The third layer, for example, transmit the forces in another direction. This is very important because the aponeurotic fascia has to transmit the forces in the multi spaces, in multi direction, okay, and it has to connect one segment to another one. The important thing is that this layer has to slide one on each other. So the aponeurotic fascia is able to adapt its structure to the movement. So between these 2 or 3 layers, there is a loose connective tissue. There is the hyaluronic acid. The hyaluronic is a loose connective tissue that act like a lubricant, act like a oil. It's very important because permit the sliding system of these adjacent layers. Okay? Like I already told you, the aponeurotic fascia has just 1% of elastic fiber because it has to transmit the forces. These elastic fiber are just 1% because, of course, the aponeurotic fascia has to be adaptable to the movement. But you can find elastic fibers much more on the epimysial fascia because the epimysial fascia covers very strongly, very very strongly connected with the muscles, and so the elastic fibers has to be much more, okay, because the epimysial fascia has to adapt to the contraction of the muscles. So remember, aponeurotic fascia consists in 2 or 3 layers of collagen fibers. Between these layers, there is hyaluronic, that is a lubricant that permits the sliding system of this layer. Okay? The cell that produce this lubricant, the hyaluronic, are called fasciocytes, that are fibroblast-like cells specialized for the biosynthesis of the hyaluronic matrix. Okay, and these are the fasciocytes that are present in the extracellular matrix in the middle of the collagen fibers. So the fasciocyte produce the hyaluronic. The hyaluronic is a loose connective tissue that permits the sliding system of the fascia. Okay, that's it. The aponeurotic fascia, this is another image of the aponeurotic fascia. Look, this silver stock that cover all the leg and reach the ankle. The aponeurotic fascia is this one, look. The aponeurotic fascia also creates the retinacula. The retinacula is just a specialization of the aponeurotic fascia. The retinacula covers the tendon and maintains the tendons in place. So the retinacula is not an independent structure, but is the same structure of the aponeurotic fascia. Look, this aponeurotic fascia continues over the ankle and create the retinacula that cover the tendons. This is very, very important. So when we talk about retinacula and when we talk about aponeurotic fascia, we are talking about the same structure. They are not independent one from each other. They are the same things. The retinacula is just a specialization of the aponeurotic fascia, a reinforcement of it, but it's the same structure. Okay, below the aponeurotic fascia, which kind of fascia we will find? We will find the epimysial fascia, like I already told you. So the epimysial fascia is this thin fascia, look, this thin layer that cover the muscle, okay? Is very, very, you can't detach the epimysial fascia without break the muscle fibers because they are connected in a very, very strongly. You can't lift the epimysial fascia without interrupt the fiber muscles. Okay, so you understand why the epimysial fascia is much more is thinner than the aponeurotic fascia. Now you understand why there is a lot of elastic fiber, because it has to adapt to the movement of the muscles. So the epimysial fascia is connected with the muscles, but the epimysial fascia continues its connection also inside of the muscle, because the epimysial fascia create other two structures that you already know. The first one is the perimysium. The perimysium is that tissue that covers a group of muscle fibers. This is the perimysium. Look, this is the epimysial fascia. This is the first image on your left, epimysial fascia, that continues inside of the muscle, creating the perimysium. Then the perimysium continues its develop in endomysium, the structure that cover one single muscle fiber. So with this lecture, I have already explained you the continuity of the fascia from the skin to the muscle fibers. So, skin, superficial fascia, deep fascia. The deep fascia is represented by the aponeurotic fascia and the epimysial fascia that covers the muscle. Then the epimysial fascia continue inside of the muscle, creating the perimysium, and then the perimysium creates the endomysium. And this structure is very, very important because it permits us to understand why the fascial manipulation, why treating the fascia is so effective for the pain, but also for the coordination, but also for the proprioception, and also for the activation of the muscles. Because if you remember the theory during the university, you know that the capsule of the muscle spindles is in continuity with the perimysium of the muscles. So the muscle spindles are that element that permit the activation of the extrafusal muscle fibers. if the muscle spindles is able to be activated, we have the contraction of the muscle fibers. If the muscle spindle is not able to be activated, we don't have the contraction of the specific muscle fibers. Why this is so important for us? Because if the capsule, I return back in this image, if the capsule of the muscle spindles is strongly related with the perimysium, and the perimysium is strongly connected with the epimysium, we understand that if the epimysium, so if the fascia, if the deep fascia is rigid, is too much tensioned, this tension goes to the capsule of the muscle spindle. If the muscle spindle is not able to be stretched because the capsule is rigid, we don't have the contraction of the muscle fibers. That's why it's important to treat the fascia, because if we release the tension of the fascia, also we release the tension that is present in the capsule of the muscle spindle. So if we release the tension, this muscle spindle is able to be activated, and so then we have the contraction of the fibers. That's why it's important the continuity of the fascia. That's why it's important if we understand the anatomy of the fascia. Because if we understand this, we are able to understand why the fascial manipulation or the other fascial techniques improve the problems of the fascia and the musculoskeletal dysfunction. Okay? This is an image that I would like to share with you, a video that represent, for example, the things that I already told you. Look, this is the superficial fascia, okay? This is the quadriceps, okay? Look, this layer that are formed by, look, 1, 2, 3 layers are forming the aponeurotic fascia. This is the aponeurotic fascia formed by 2 or 3 layers of collagen fibers. Look, these layers side one on each other because in the middle there is this lubricant represented by the hyaluronium. So this layers layer one on each other. This aponeurotic fascia cover the epimysial fascia that is strongly connected with the muscle that is contracted. Okay? Do you understand this three-dimensional organization of the subcutaneous tissue? Okay, it's very easy to understand. Okay, so the fascia is richly innervated. It's very, very important because if we know that the fascia is richly innervated, we know that the fascia probably is related also with the nociception. Look at this data. This is the brachial fascia. That is the fascia that cover, for example, the region between the shoulder and the elbow. This is the antebrachial fascia. That is the fascia that cover the upper limb, but from the elbow to the end, okay? And this is, for example, the retinacula. Do you remember the retinacula? The specialization of the aponeurotic fascia, so the fascia that cover the joints. This picture, this image explain that the retinacula, especially the retinacula, so the fascia that is present in the joint, are richly innervated. Reinnervated by 3 nerve endings, corpusculi and Pacinin corpusculi and Ruffini and Pacini corpusculus. So it's very, very innervated. This is very important because the fascia is is very, very important for the proprioception because it is able so to feel the tension, the pressure, and also the nociception. Of course, the innervation, there is much more innervation in the retinacula, look, than in the fascia between the shoulder and the elbow, or in the fascia between the elbow and the end. Why? Because the joints are very important. The brain has to know how is moving the joints. So the nerves has to be a lot, has to be many, because the brain has to know a lot of information about the movement of the joints. In the space between two joints, the nerves are less, because here the fascia has another task. It has just to transmit the forces between one joint to another one. So in this area, the fascia has not to be too much innervated, because here the task is just to transmit the force. In the joints, the fascia is much more innervated, because it has a very important role of proprioceptions. Okay? The tendons are not so well innervated like the fascia. So this is the image that now you already understood very well. We have to reach this portion of fascia, like I already told you. So we have to reach the deep fascia. The deep fascia consists in the aponeurotic fascia, the yellow one, and the epimysial fascia, the gray one. Between these two structures, there is a lot of hyaluronian, the loose connective tissue that I already explained to you. This lubricant is very important because permit the sliding system between the epimysial fascia and between the aponeurotic fascia. This hyaluronian is present also in the middle of the aponeurotic fascia, between the layers, because like I already told you, the aponeurotic fascia is formed by 2 or 3 layers that have to slide one each other, okay? So here we have hyaluronian that is formed from these cells, the black one. This is the fascia site, but the hyaluronian is present especially between the aponeurotic and the epimysial fascia. The hyaluronian is present also between perimysium and endymysium, because also the motor units, also the muscle fibers, have to slide one each other if you want to have a good movement. So we have to reach this portion of the fascia. If in this portion of the fascia there isn't a sliding system, the fascia doesn't work properly. We start to have a lot of problems. If there is no sliding system, the fascia become rigid, and we start to have problems like in proprioception, problems in coordination, and problems also for pain, in the pain. The patients start to have pain. The patients start to move in a pathologic way the joints. In fact, these are the layers of the deep fascia, for example. Between the layers, like I already told you, there is this hyaluronian, okay? The layers, okay, of the fascia are healthy, okay? They don't have problems, okay? The problem is between the layers, because we don't have a sliding system, so they are not able to slide one each other's. The fascia, if we look at some image, we have echography, or we can see a fascia that seems thicker, okay, but it's just thicker because between this layer there is too much hyaluronian. The problem is that if the hyaluronian start to be, there is a lot of hyaluronian, too much hyaluronian, this hyaluronian start to self-associate, and this self-association generates a variety of intermolecular aggregate structure. So the hyaluronian increase its concentration, And hyaluronian from a lubricant becomes adhesive. So a lot of hyaluronian create an adhesive structure. From oil, the hyaluronian becomes something like glue, honey. So the fascial layer are not able to slide one each other, and all the structure become rigid. That's it. We call this lack of sliding system, this self-aggregate of hyaluronian chains, we call it densification. So if there is too much hyaluronian between the fascial layers, if there is not a sliding system, all the fascia become rigid. We have a lot of tension, and so we have a problem in coordination, proprioception, and pain. This is an example. So this is a physiological fascia. Look, there are 3 layers of the fascia. Inside of the fascia, there are a lot of receptors that I already told you. This is 3 nerve endings that if they are embedded in a physiologic fascia, they works like proprioceptors. So they send to the central nervous system stimuli, feedback of tension, of movement, of pressure. But if these receptors are hyperstimulated, they start to send to the message different to the brain different message. They start to send nociceptive pain message because they are overstretched by this densification. Look, this densification create a tension in this area of the fascia. This tension creates new force line, but these lines are pathological, are different. They overstretch these receptors that start to send to the central nervous system message of pain. So our aim is just to find this densification and remove it. How we can remove it? Using our hands, the fingertips, the elbow, and the knuckles. And now we understand how. Look, for example, this is a densification on your left. So this is a self-aggregate change, create a tension, the fascia start to be rigid. So we don't have sliding system. We have to restore this situation in a normal way. Which are the elements that create a densification? For example, overuse syndrome, trauma, skirts, visceral problems. All of these aspects create a densification. The fascia start to be tensioned, and the patient start to have pain. So how we can restore this situation? So this is, for example, glue. Okay, this is honey. Okay, we don't have a sliding system. We treat the patient with our knuckle, with our fingertips. We create, okay, we create a heat. We, how can I say, we increase, okay, the temperature of this area till 42 degrees. This high temperature start, okay, to disgregate all of these chains, and so we restore the sliding system of the fascia. So the hyaluronian, okay, will disgregate. We create just one chain, one line of hyaluronian. Before we have 2 or 3 lines of this hyaluronium, so we have too much hyaluronium. We treat the patient. We create a lot of high temperatures, 42 degrees, and then the hyaluronium return back on one line. Also, and so it return back. It return to be something like a oil, okay, a lubricant. So we have normal sliding system. That's it. So, talking about the structures that I already explained to you, if the problem is in the venous return, in the skin, lymph drainage, and so on, probably the structure that is involved is the superficial fascia. If the problem is about proprioception, coordination, or pain, the problem is much more related to the deep fascia. And when we talk about deep fascia, we talk about the aponeurotic fascia and the epimysial fascia. So, to treat the superficial fascia, we use a soft massage and using a large surface, but this is something that we will explain to you to the third level, okay? In the course of the third level. In the first, second level, I will teach you how to reach the deep fascia and how to treat it. So, creating a deep massage, a friction, using a small surface. That's it, okay? Because we have to create a high temperature, 42 degrees, that permit me to disgregate, okay, to create the sliding system of the fascia. That's it, okay? Look, probably some patients or probably some therapists have already told you that the fascial manipulation treatment treat the patient distant from the pain. But why we are doing this kind of treatment? Because the continuity of the fascia answer to us. Because, for example, if we have a patient that have, this is the thoracolumbar fascia. Remember, the thoracolumbar fascia is aponeurotic fascia, okay? So you can detach this from the underlying muscles. If a patient has a low back pain, for example, why, for example, if I treat this patient, for example, I treat the ankle, why probably I will improve his pain? Because the continuity of the fascia can answer me. Because, look, this is the thoracolumbar fascia. The thoracolumbar fascia create a continuity also in the lower limb. It covers the hip and it continues its development also in the thigh and covers all the thigh. And then it continues creating the retinacula. Look, this is the retinacula of the knee. But it doesn't stop. It doesn't stop there. It continues also in the ankle, creating the retinacula of the ankle. So, for example, if a patient has now low back pain, but for example, 2 years ago he had a very strong sprain of the ankle, probably the ankle sprain, okay, created a tension in the ankle. This tension through the fascia goes reach the segments that are above, reach the fascia of the thigh, and then this tension from the thigh goes to the thoracolumbar fascia. So the patient start to have pain. So if we treat the ankle, we release the tension there, and so releasing this tension in the ankle, we release also the tension in the back of the trunk. It's not magic, okay? It's not placebo. It's continuity of the fascia. That's why the fascial manipulation treat the patient distant, away from the present pain. I can give you another example. This is the same thoracolumbar fascia. Look, it creates continuity with the lower limb, like I already told you, but also it creates continuity also with the segments above. So, through the latissimus dorsum, through the trapezius, from the thoracolumbar fascia, we can reach also the neck, the shoulder. So if a patient comes to you and he has low back pain, and you don't know why he has this low back pain, he has an unknown sources. If, for example, 1 year ago, 2 years ago, 10 years ago, I don't know, he had a big injury in the shoulder, this injury in the shoulder could create tension in the shoulder that goes down, okay, reach, for example, the trapezius, reach the latissimus dorsi, and so reach the thoracolumbar fascia. And so the patient started to have pain. So if you don't treat the shoulder, you are not able to fix the pain of the patient. If you don't treat the ankle sprain, the ankle, you are not able to fix the thoracolumbar fascia. If you treat only the thoracolumbar fascia, probably the patient feel better, but the results will not be maintained in the future because the tension in the ankle or, for example, in the shoulder is still there. You have to treat them. That's why we believe to the continuity of the fascia, and that's why we treat the patient with a global approach. But for example, this is a transversal dissection of the lumbar region. This is the rector spine. This is the thoracolumbar fascia that covers posteriorly the rector spine. Look, the thoracolumbar fascia continues also with the large muscles of the trunk. So external oblique muscle, internal oblique muscle, and a transversus muscle. These muscles create a connection between the thoracolumbar fascia that is posteriorly with the abdomen that is anteriorly. So, for example, low back pain could be strongly related also with a tension in an anterior part of the abdomen. Why not? The people that have dysmenorrhea, the patients that have pain, visceral pain, okay, on stomach, that have, for example, and so this pain of the stomach, visceral pain, create tension of these structures. Scars, okay, in anterior part of the abdomen after a delivery, for example. These problems could create a tension there, and this tension can reach the thoracolumbar fascia behind. So we have to treat anteriorly the patient to improve the pain posteriorly. It's not magic, I would like to underline this concept, but it's just continuity of the fascia. And if we know the anatomy of the fascia, we know how to treat the patient and we understand where to find the source of the present pain, the origin of the pain. How we can find, how we can create the hypothesis, how we can treat the patient, how we can organize, plan the treatment. We use the assessment chart. That is, this tool is very, very important for us. It's very, very important. Without assessment chart, we are not talking about fascial manipulation, because fascial manipulation is not consists not in treatment or of 1 or 2 points in a random mood, but it consists in a reasoning, in a creating hypothesis, thanks to the assessment chart. Okay, without assessment chart, we are not able to perform a good fascial manipulation treatment. And during the course, I will insist, I will explain you very well how to create a good, how to fill a good assessment chart. The treatment consists in this aspect. So at the beginning, we will give the infos to the patient. Then there is an interview. This interview represented by the fascial manipulation chart. Then we will create an hypothesis that can explain us why the patient has this kind of pain. Then we will perform a motor verification, then a palpatory verification, and then we will perform the treatment. So let's talk about the information. At the beginning, we will talk to the patient. We explain that the essential features of the method. So that is a method that has a global approach. That is a method that probably create just a little bit it's a little bit painful because we create this kind of friction on a specific point. So it could be a little bit painful for the patient. We will explain that after the treatment, especially in the site, in the region where we have created the friction, there will be a tenderness for 2 days, and it is normal because we have created a small inflammation of the region, because we have increased the temperature until 42 degrees, because this increasing of temperature permit us to create the sliding system, okay? So to break, to cut the long chains of hyaluronian, okay? And I would like to underline this aspect that fascial manipulation has no contraindication, so we not create anatomical lesions, okay? This is the assessment chart of the fascial manipulation. In this chart, we will put inside, we will write down all the data of the patients. So this is very important because this assessment chart permits us to create an hypothesis, okay? Probably now you don't understand how to use it. There are a lot of fields inside, but don't worry, it's very, very easy to understand. And during the course, I will teach it properly, and I will lose a lot of time for this. So don't worry if now you find a lot of fields and you don't understand how to fill them, but don't worry, it's very easy, much easier than you think. The compilation of this assessment chart is very easy. You have just to remember that you have to note down only relevant data, the data that you think are related to the present pain of the patient. You have absolutely to investigate the futures of the pain, okay, the pain onset. So the movements that create the pain of the patients. So you will understand in which plane the pain is much more present in a sagittal plane, so in the movement along extension or flexion, in the frontal plane, in movement that in abduction or in adduction, or in the horizontal plane in intra-rotation or extra-rotation. If you have understood the continuity of the fascia, and especially if the patient has pain, but he doesn't know why he has this kind of pain. So this pain has an unknown onset. Surely the problem is not there where the patient is feeling the pain in the same segment, but probably the source of the origin of the present pain is present elsewhere in another segment. Like I already told you when I talk about the low back pain. For example, I have now low back pain, but I think that 3 years ago the problem started from the ankle after an injury when I was playing soccer. So my hypothesis is that the tension from the ankle reach the thoracolumbar fascia through the continuity of the fascia, so through the fascia of the leg, of the thigh, and then gluteus, and then reach the thoracolumbar fascia. So for us, it's very, very important to ask about the story, the history of the passion, because frequently in the history of the passion, we find the origin of the present pain. So when we are forming the hypothesis, like I already told you, we have to ask to the patient if he had a problem of overuse, if in the past he had problems like surgeries, trauma, or other previous pain. If in the past he has internal dysfunction, dysmenorrhea, for example, gastritis, some visceral problems that create a tension on the fascia of the abdomen, for example, and then from the fascia of the abdomen, the tension spread out and reach other segments. Also, this tension created in the fascia are also a consequence of psychosomatic problems. So when you have to talk about with the patient, you have to understand that the problems comes from these four aspects: overuse, surgery, trauma, previous pain, internal dysfunction, or psychosomatic problems. When you're forming the hypothesis, you have to understand which segments are involved with the patient's problem. The compensation is are ascending or descending. If, for example, I have low back pain, and in my opinion, the problems comes from the ankle sprain, in this case, the compensation is ascending from the ankle. If, another example, my low back pain, in my opinion, the problems come from a surgery of the left shoulder. That I have this surgery 2 years before the low back pain. I think that the compensation is descending from the shoulder. So the tension from the shoulder reaches thoracolumbar fascia. So please, using the assessment chart, we have to be able to establish the causes and the consequences. Okay? After the assessment chart, we perform the motor verification. The aim of the motor verification is just to objectify the results of the treatment. It's just a picture pre and post treatment. We ask the patient to move the segments, the painful segments, following the three different planes, motor planes. So we ask to move in the sagittal plane, extension, flexion; in the frontal plane, abduction, adduction; and horizontal plane, or intrarotation, extrarotation. We try to exacerbate the symptom. Then we treat the patient. After the treatment, we will repeat the same motor verification, and we will understand if the patient has improved his situation. That's why the motor verification is very, very important, because permits to the therapist to understand if the treatment was good or not, if the hypothesis was the right one, if the point chosen were the best one. Because if we find and if we treat the best point, the patient improves the situation. If we treat points that are not so important, the patient does improve his pain. We are not able to fix the patient. That's why we use the motor verification, because it permits us to understand if we are doing a good job. What we consider during the motor verification: the range of movement, not only the pain, but also the range of movement, the strength, if the patient use compensation, the speed of movement, and also, why not, the proprioception. So we consider all of these elements. We consider the pain. We perform the motor verification before the treatment and after the treatment. And then we'll discover if the treatment was good or not. After the motor verification, we perform the palpatory verification. The palpatory verification is very important because decides which point we are going to treat today. It permits us to find the most densified points. It permits us to find the densification. So where the fascia is rigid. So where the fascia has not the sliding system. That is very important because we have to find this point. If we don't find this point, the pain of the patient will be not resolved. So the palpatory verification is defined by the hypothesis formulated after the interview, but also by the information obtained by the movement verification. Without palpatory verification, we cannot continue our treatment because this part of the treatment permit us to find the points. Usually during a treatment we treat 4, 5, 6 points because the treatment is a little bit painful and treating 4 or 5 points is enough, okay? So we have to find them correctly because if we choose the wrong points, we're not able to fix the patient's pain. So the palpatory verification permits us to understand which muscles are much more involved with the pain of the patient. The muscles that are present that move the segments of the patients in a sagittal plane, also in extension and inflection. Or probably the palpatory verification suggests us if the problem is related to the frontal plane, so the muscles that move the segments in adduction or in abduction, or in horizontal plane, interrotation or extrarotation. The palpatory verification suggests us also if the problems came from an internal dysfunction. So if the origin of the problem is from the visceral fascia, from the visceral organs. This kind of treatment we will able to treat. I will teach you how to treat during the third level, not in the first and second one. And then we will understand if the problems is much more related to the, for example, to the retinacula. So treating a diagonal or a spiral. So that's it. We will treat the muscles following the planes, sagittal, horizontal, frontal, or we will treat the retinacula. So treating the points of the fascia that are present in the joint. The internal dysfunction is something that I will teach you later because in the first and second level there are many things to do and to learn. So we will understand them all this concept of the fascia step by steps. So I would like just to introduce you an example, a case report. For example, this is a physiotherapist. We have treated her 2 years ago during a fascial manipulation course. For example, this patient had a low back pain in this region, okay? She complained this pain from 3 weeks, okay? She had a lot of pain. And so, but she doesn't know why she has this kind of pain. She has this pain is a unknown onset. So probably the origin of this pain is not in the same segment, but we have to find the origin of the pain in some other segments. So this present pain is just, in my opinion, a compensation, is the tip of the iceberg, is the last ring of a chain. We have to find where is the cause of the present pain. So we ask about her story, about life, his story life. And in fact, she told us that 8 years ago, he had a whiplash. He had a big trauma when in the car 8 years ago, and he had a big trauma that it created a lot of problems for the pain in the thorax, in the neck. Was maintained for 1 year, so it was a big trauma. But also 5 years ago, she had also a surgery of the knee. And so also this surgery probably created a lot of tension in this site of the body. So in my opinion, this low back pain is just the last compensation. It's just a consequence of the tension that comes from the thorax cause of the whiplash, and it's a compensation also of the tension that comes from the knee cause of the surgery. That's it. So look, this low back pain is just in the middle between this previous pain and this previous pain. So what we have treated, okay, we have I don't want to explain you which point we have treated specifically, because you will not understand, but I would like just to share to you that we have treated some tension in the neck, 1 point in the neck, 1 point in the thorax, another point in the opposite side of the pelvic region, so in the gluteus, but on the left one. I would like to remind you that the pain perceived by the patient is there. So we treated these 2 points, then this is the third one, and then at the end we treated also a point in the retinacula of the knee. So we have treated 4 points, and the pain of the patient decreased a lot. And we have created a video. This is during the course. Excuse me if there are these shapes, green shapes, but we have to cover the face of the courses. In Italy, there are a lot of problems of privacy and so on. So this is the motor verification that I have already explained to you before the treatment, okay? Okay. Okay. Then this is the second motor verification after the treatment of the point in the neck and the point in the thorax. So we have treated these points, and then we have performed a second time the same motor verification. The situation changed a lot. It's not magic, I would like to repeat this aspect. It's just continuity of the fascia. Probably there is a lot of tension, And this tension through the latissimo dorsi and trapezius has reached the thoracolumbar fascia. The thoracolumbar fascia was stretched too much, and so the free nerve endings that are present inside of the fascia, overstretched, started to send pain messages to the central nervous system. That's it. Okay? At the end, we have treated also the points in the left part, look, in the left part of the pelvic region, and the point in the knee. Look, probably in the image you can see also the red, the inflammation of the point treated. Okay, so this is the movement, and it changed a lot. I would like to repeat. So This is the first one. Then second, third. This is the motor verification inflection extension, so along the sagittal plane. This is another motor verification. The points are the same, but he has improved also this situation. This is before the treatment. Okay, look. Before the treatment. This is after the treatment of the neck and the thorax. Okay, look. Okay. And this is after the treatment also of the pelvic region of the gluteus and the knee. This is not it's a patient, of course, but it's a physiotherapist doing a course. So the treatment was effective. So the motor verification here is telling me, okay, Stefano, the pain is the range of movement. The pain is decreasing. The range of movement is increasing. The patient feel less pain. So probably your hypothesis is right, and probably the points that you have chosen are the best one. So good. The motor verification confirm that we performed a good treatment. In this period, for a lot of things, especially for the COVID situation, there are a lot of fake news, but there are also a lot of fake news about the fascial manipulation treatments. And I would like just to explain you this kind of fake news. So, guys, are you still with me? Danilo, everything's good?
Yes, yes.
Okay. So, guys, the treatment hurts a lot. Absolutely not. Because if you know the anatomy of the fascia, you don't have to push too much to reach our target, and so the deep fascia. Because the deep fascia is just above the muscle, is a little bit below the skin. So the pressure is light. You don't have to push too much. If you push too much, of course you exacerbate a lot of pain. I agree. But during the courses, I teach you that you don't have to push too much. You have just to push a little bit, just because you have to bypass the subcutaneous tissue, and so the fat lobulus, the superficial fascia. When you reach the deep fascia, the patient feel a little pain, something like pins and needles pain, a small, the tip of the knife. Okay, just to describe you the kind of the pain. It's not a big pain like for example, like to treat a tender point. It's not, we don't treat a tender point. We treat the fascia, we treat the densification. And when you treat the densification, the patient feel a little bit of pain, of course, but it's a small pain, an acute pain, like a pins and needles, like the tip of the knife. If the patient feel this kind of pain, you are treating the right structure. So please, the treatments of fascial manipulation does not hurt a lot. Okay? Okay, another fake news is this. Okay, fascial manipulation is not so good for children or elderly person. This is a big fake news because, for example, in my own experience, in my practice, daily practice, I treat all kind of passion from the children, 2, 3 years old, till the old man, all the persons, till 90. Yesterday, I treated a patient that he was 80, 85 years old. Of course, you have to be careful. Probably the children, you will treat them using just the fingertips, for example. Also for the old people, for the elderly person, you can use just the fingertips or probably the knuckles. Of course, if you have to treat an athlete with a lot of muscles, young and so on, of course, you have to treat sometimes the elbow. But you don't have to use the elbow because you have to push too much. Absolutely not. It's just because we have to. I don't know in it. I don't know in Serbia, but in Italy, probably we have to work till 80 years old. So you have to protect, the therapist have to protect his hands, his fingers. So if you treat 10, 12 patients per day using fascial manipulation, it's a good thing if you change your tools. So sometimes you use your elbow, sometimes you use the fingertips, sometimes you use the knuckles. You have to understand when use one and when use another one. Of course, if I have to treat the children's, of course I will use the fingertips. Or the same things for the elderly persons. Okay, so you can treat everybody because, like I already told you, fascial manipulation does not have contraindications. Okay. I already told you this thing. The therapist ruins his or her hands. Absolutely not. If you push too much, of course, you will ruin your hands. But I already told you, you don't have to push too much because deep fascia is above the muscle, okay? And if you change the treatment, if you change your tools, you don't ruin your hands. I will teach you which points are much more approachable. You have to which points are have to be treated with the elbow, which point have to be treated with the fingertips, which point have to be treated with the knuckles. I will teach you all of the things because after a lot of year of clinical experience, I understood that, for example, the points that are present in the gluteus probably is better for you if you use the elbow. If you have to treat, for example, the neck, it's you can use also the fingertips. It depends on where is the densification and on which segments and so on. Okay, it's not tiring. I treat per day 10, 12 patients per day, and at the end, in the evening, I'm not tired because I don't have to push too much. Because I'm tired because my brain is tired, not my body. Because you have to, like I already told you, we don't use fixed protocols. So each patient has a different source of the present pain. So you have to think a lot. You create a lot of hypotheses during the day. And I like it so much. I love think a lot. I love create a lot of hypotheses. I love image the connection between the fascia, how a distal segments could affect another segments and so on. So yes, in the evening I'm tired, but my brain is tired, not my body. So this is another fake news. Okay, fashion manipulation is not tiring. The last one is this. Okay, the fashion manipulation is not so easy integrated with other therapeutic approaches. This is a fake news because you can integrate it with other manual therapy with other. I like, for example, integrate it with the exercise because I think that these two aspects together are the best solution for the patient. So treatment of fascial manipulation and then therapeutic exercise, in my opinion, is the best choice for the patient. But if you are osteopaths, if you are have other manual therapy experience, you can integrate this together. My suggestion is this: please don't mix the methods together in the same treatment, because you will not understand what are you doing. You will not understand which is the problem of the patient, and you will not understand which method is the best one for that kind of patient. So if you want to integrate with other approaches, you can do this, but in a good way. Don't mix all together. You will not understand nothing. Okay, that's it. So I just introduced you the first and second level, the course that Danilo has planned for this summer. This is the program of the first level, in consisting 48 hours of course. So it's in the first level I will give you an introduction of the fascial anatomy, of course deeper than the introduction that I already explained you today. I will talk about the physiology of the fascial system and how the fascia is so important for the muscle spindles and why we have to consider this aspect. I will explain you how to how to use the assessment chart that for me it's very, 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 very important to create the hypothesis. And of course, I will teach you the points of the fascial manipulation, the center of coordinations. Okay, so all the points that are present in the muscles that move our body in the three spatial planes, so sagittal plane, frontal plane, and horizontal plane. And of course, we will perform. I will perform more than one treatment in front of you, and you will perform. You will start to treat the patient already after the first level. I will teach you all the points. I will teach you how to perform the motor verification, the palpatory verification, and I also will teach you the assessment chart. So after the first level, you will already able to perform a fascial manipulation treatment. But at the second level, that is a second course, 48 hours of course, I will teach you other points, because if in the first level I will teach you the points that are present in the muscles, over the muscles, in the second level I will teach you the points that are present in the retinaculum, we call them line of fusion. So in a specific side where two or more muscles meet, insert in a specific site and create a new line of forces. It's difficult to explain now, but are other points very, very important, like the CCs, the points of the muscles. These second points are very, very important too, and we use these points also for the treatment of the visceral problems. So that kind of patients that, for example, has pain both of the shoulders, And this kind of pain, for example, depends of a problem of the esophagitis, of a problem of gastritis, or dysmenorrhea, or a problem of the I don't know, of other visceral organs that are inside of the trunk. These visceral organs create an inflammation, so create tension, and then they affect the muscles and the fascia of the trunk, creating then the pain in the shoulder. For this kind of treatment that have a visceral origin, the points, the center of fusion that I will teach you in the second level are very, very important to be treated. But in the first level, the point, the CC, are very, very important too, of course, and you have to learn it to improve the musculoskeletal dysfunction. So the patient that have pain during specific movements and during their daily life. So guys, then Danilo will introduce you the course, okay? I just want to show you that I will show you the points on the skin of the patients, okay? I will draw the points so you can understand where you can find points. For example, I write the points on the skin of the therapist, and I will use a camera so you can watch what I'm doing, and when in the middle and while I'm explaining the points, you will write the points on the skin of your partner, and you will find the point and you will treat it while I'm explaining. Of course, I will interact with you during the practical part, just to show you how to find the point and how to treat it. In this case, this point that is below to the great back, I'm explaining to this colleague that is better if he treat this point using the knuckle, for example. Okay, and these are the points of the fascial manipulations. Okay. So guys, thank you so much, and we are waiting for you because I think that fascial manipulation course is very important to improve our clinical experience, and now the fascia is very important. It was a missed tissue, but now it start to have a great role for our clinical, for our patients. So it's good if we understand the anatomy, the physiology, and if we understand how we can treat it. Guys, thank you so much, so much. I return back. Where are you guys? Okay. Stop sharing. Someone is sleeping. Danilo, someone is sleeping in your point of view.
So you have a few questions in the chat, so maybe you can first answer to them, and then I can say a few things about the course.
Yes, hi Stefano, I will send my question now. Or it is possible to deform fascia all around the body. In other words, it is in some areas too hard to deform fascia manually ever for a short time. I would like to repeat this aspect. We are not able, nobody is able to deform, to change the collagen fibers. Okay, the layers are healthy. The problem is not in the layer, inside of the layer. The problem is in the loose connective tissue. The problem is the hyaluronian. So that kind of liquid, that kind of lubricant that is between the layers, between the aponeurotic fascia and the epimysial fascia. If this lubricant is not organized along one change, but it starts to self-aggregate, the lubricant start to create more than one chains. So if you have many chains, the lubricant create a lot of viscosity of the structure. So from lubricant, from oil, the hyaluronic become adhesive, become like a glue, honey. So we don't have sliding system. The fascia start to become rigid, and so all the elements that are related to the fascia, muscles, capsules, ligaments, free nerve endings, muscle spindles, start to work start in a not in a proper way. So the patient start to move in a pathological way, starts to have pain. So we don't change the layers. We are not able to do this. Nobody is able. We change the liquid, okay? We change the lubricant that is between. We restore just the sliding system. If you restore the sliding system, the problem, the pain decrease, okay? The second one, it is necessary for it in order to make a change in pain. Yes, I already answered to you. Hypothesis that fascia is a bit contractile. It's like a few-year-old theory. I know. Opinion. Thank you. Yes. Yes. Is a little, yes, we are studying about this. Carla, especially in the last 2 years, is start to hypothesis that the fascia could be contractile because in the fascia we have fibroblast, fasciacyte, but sometimes if the fascia doesn't work properly for a long time, or after, for example, surgery, the fascia produced another kind of cellular, another kind of cell, that is the myofibroblast. This myofibroblast create a tension inside of the fascia that then create all the consequence that I have already told you. So yes, it's a little bit contractile, but thanks to this new kind of cells that we are studying to better understand how does it work, but we are just at the beginning of it, okay, of the study, excuse me. So my question is, what is your experience with this treatment with patient with chronic back pain or some other part of the body? Oh, okay. Yes, of course, we treat this kind of patient that have chronic back pain. Of course, with chronic back pain, the problem is not related only to the connective tissue, of course, but the problem, the tension, the connective tissue is just a part of the problem of the pain of the patient, because of course there is a problem also of the sensitization of the central nervous system. There is also a problem linked, related also to the exercise. So in this kind of patient, I treat them, of course. Probably the pain of the patient is I'm not able to improve to fix the patient, the problem of the patient, the pain of the patient easily and quickly, but it takes much more time because there is a sensitization of the central nervous system, and also because I will integrate the fascial manipulation with the exercise that help me to create the normal sliding system, help me to create a new physiological line of forces of the aponeurotic fascia. And so it's a little bit difficult to manage, but yes, we treat them, but we have to know that there is this sensitization of the central nervous system and also a sensitization of the fascia, because if you have pain, a chronic pain, I am pretty sure that you have created in the last years a lot of new nerve endings that are pathological. And so there is not only a sensitization of the brain, but there is also a sensitization of the connective tissue. And so you have to wait you have to treat, you have to fix the tension of the patients. You have to restore the normal tension of the fascia, but also you have to wait that the fascia creates other free nerve endings that are physiological and not only pathological. I don't know if I was so clear. Can you treat fascia? Can you treat fascia through different methods, not just elbow, knuckles, fingers? I saw a therapist. Yeah, yes, you can treat in a different way, but I prefer my hands because if you have a powerful hands, you can, in my opinion, you are able to understand much better where is the densification, because you have to feel the densification under your fingers. You have to feel the densification. How you can find it in the body of the patient under your fingers. You think that there isn't a sliding system, but also you feel something like rise, something like doesn't like the teeth of the comb, something that scratch, something like this. So if there is no sliding system, if you have a sensation like rise, something like this, you have found a densification, but you have to use your fingers and also the elbow to treat them in a proper way. If you use the tools, other tools, yes, but we is not our method because we don't believe in this kind of treatment. We think that are not so specific like when you use your hands. But listen to me, believe me, you don't ruin your hands because the pressure is very, very light, and you can treat a lot of patient during the day because it's not I'm not tired at the end of the day. You don't have to push. You can be much more specific to the point just using the hands. This is my opinion, but also the opinion of the Luigi, Carla, and Antonio Stecco. My question is, what is I'm losing is what can you treat fascia? No. When you treat fascia, does it any influence on mental relaxation? Yes, in my opinion, yes. For example, in the last year, I'm collaborating with a psychotherapist, and yes, we think that there is a strong relation with mental issues and the fascia, because the fascia in the fascia you can find not only the tension, all the pain, all the traumas, all the scars, all the surgery and so on, but also the problems of your lives. When I talk about psychosomatic problems, I explain in this kind of problems. So the patient that have depression, anxiety, or some other problem, psychological problem, the fascia has an influence of this kind of problems. And if you treat the patient, if you treat the fascia, you can improve, of course, of course. You don't resolve, but you can help the psychotherapist to help the person to improve his mental situation. Yes, because I'm pretty sure, we are pretty sure that there is a relation between mental issues and fascia. So, and I treat a lot of patients with kind of problem with a good results. But we are just in the beginning. There are a lot of things to do. Like I told you, fascial manipulation is a young method. We have many things to discover, and we will discover it. I'm pretty sure. How long those treatment list? Yes, how long one treatment is something about, it depends. How many pounds do you want to treat? In my own experience, I treat, the treatment is a session is something like 45 minutes. This is my own experience. But I have other teachers, my other colleagues, that, for example, stay with the patient half an hour or someone 1 hour. It depends. You can treat three, if you treat 3 points, 4 points, half an hour is enough. If you treat 6, 7 points, this is my, for example, my clinical experience. 45 minutes are enough. You have to understand that 10 minutes at the beginning is just for assessment chart, so to create the hypothesis. 10 minutes, 10, 12 minutes. Then a few minutes for the motor verification, okay? And then a few minutes for the palpatory verification. So then you have 20 minutes for the treatment. And you know that each point takes something like 3, 4, 5 minutes to be released. So in 20 minutes you can release 4, 5, 6, 7 points, yes, in an easy way. Okay, so 45 minutes I think is the treatment of the fascial manipulation. That's it. Can it be integrated with other manual techniques? Yes, like I told you when I talk about the fake news. Yes, you can use the fascial manipulation with other techniques. But my opinion, you don't have to use the methods, the two methods. For example, I don't know, Maitland and fascial manipulation all together in the same treatment, because you don't understand nothing. They have two completely approach, two different approach. So in my opinion, if you treat the patient for the first, at the beginning, you start with Maitland, and then you have 5 minutes more at the end of the treatment. You decide to treat 2 points of the fascial manipulation just to finish the treatment. In my opinion, this kind of treatments are not so good and are not so effective. And you don't understand which method improve really the situation of the patient. And so yes, you can use integrates with other methods, but please in a correct way. Okay, today I decide to treat this patient with fascial manipulation. Today and for the next 2 treatments. I would like to understand how fascial manipulation is effective to this patient. Then you can start with the, I don't know, Maitland technique, or you can do the same, or you can start with Maitland and then continue with the other treatments with fascial manipulation. Do what you prefer. I'm here to say you, please don't mix the same treatment, the methods in the same treatment. The exercise, in my opinion, is the best aspect that you can integrate with fascial manipulation. You treat the point, you release the tension, the patient feel much less pain, then you add the exercise, and so you can improve the results of the fascial manipulation, because with the friction before the treatment, the fascia was rigid, doesn't slide. Then I create a friction, okay? I restore the sliding system, but the exercise maintain the sliding system, improve the sliding system. So after the treatment, I suggest to the patient, hey, please go to the gym, go to the a motor expert, learn exercise for your shoulder, because the movement maintain the sliding system that I have created with the treatment. That's why I love the exercise, because it helped me also that I'm a physiotherapist. Do you have experience with patients that have musculoskeletal issues? Yes, of course. For example, I treated. Do you have experience with? Excuse me if I didn't read. Do you have experience with patients that have musculoskeletal issues due to the lesions of central nervous system? Yes, we treat them, and it's very, very. In the last 2 years, we started to discover a lot of things about this kind of patients. And for example, yesterday, I have treated this kind of patient, and you can prove his situation because you know this kind of patient that have this spasticity. This spasticity create tension of the fascia, and so this tension of the fascia lately create pain, compensation, and also increase the tension of the muscles. So the muscles are already tensioned by the spasticity. But after 2, 3, 4 years, this spasticity creates tension of the connective tissue. This new tension of the connective tissue creates pain, new compensation, but also increase the tension of the muscles. So if we treat the fascia, we are able to improve this kind of situation. So this kind of patient probably improve, perceive less pain. We improve the range of movement. So if is going to start a physiotherapy exercise, also the exercise are much more effective if the fascia is released. So you are able to learn new exercise, new activities, because the fascia is free to slide. If the fascia stay rigid, the consequences are a lot, and so the handicap of the patient is much more is bigger, of course. Okay, I think I have already answered to all the questions. Guys, thank you so much. Danilo, I please, if you want to add some information.
So first of all, I would like to thank you for this lecture, and for me, I cannot wait August and to hear this all in person. So I will just tell these things in Serbian, so I think it's easier for all the people. Znači, kao što je rekao već Stefano, sve ovo što smo pričali danas jeste kao neki znači, uvod za kurs koji ćemo održati po prvi put u Srbiji od 27. avgusta do 1. septembra. Kurs se održava u Novom Sadu. Za sve informacije koga interesuje sve vezano za kurs, možete se javiti meni, da li na mail, da li preko telefona, da li Instagrama, Facebooka, kako god. Cena kursa je ove godine isključivo 450 € kao promotivna cena iz razloga zato što STECCO institut prvi put održava kurs u našoj državi. Od sledeće godine seminari njihovi će koštati 550 €. Broj mesta je ograničen, trenutno imamo 13 rezervisanih mesta i ostalo je još, to je 14 mesta, ostalo je još 10 slobodnih mesta. Tako da, ukoliko ste zainteresovani, slobodno se javite i u principu to bi bilo to. Okay, that's it for today.
Oh, very fast, great. Guys, thank you so much. I'm so happy to enjoy with you this course. I'm so happy to come to visit your great country. Thank you so much, Danilo, to permit me to stay here and share this knowledge, this concept to all of you. Excuse me if it was a little bit boring, but there are a lot of things to explain, and I hope that you have understood all the concept that I shared with you today. Guys, I wait you to the course, and thank you so much once again.
Samo još jedna stvar, zaboravio sam da kažem, na kursu će biti prevodilac, znači bit će prevod na srpski, ovde sada na webinaru je bilo malo komplikovano pa smo to izostavili. So I just wanted to say that in August there will be translator. It was a little bit difficult here just to translate all the time, but in August there will be a translator.
Perfect. So there's no problem. We will. I have already done the courses with the translation last year in China, for example. So it's good. I think it's better. So we don't miss nothing about the fascia in this. I think you have understood with language today with the language. Did you have some problems? Have you understand everything that I explained or not?
Yeah, most of the people here know English really good, but because few of them they don't know it so good. So, but for them we have to have translation. But most of them are really okay.
Okay. Great. Guys, see you soon. Thank you so much once again. Okay. Ciao. Bye.